This is Max Cameraman for the Fundamentals of Sports Medicine. Today we're going to be talking about elbow cases, osteochondritis dissecans, or the OCD lesion, as it's sometimes called. Once again, follow us on social media or email us for future topics. And as a disclaimer, FSM should not take the place of a visit with a medical professional, nor do we have any financial disclosures at this time. Now, we're going to use a case as a jump-off point, as usual. In this case, we have a 15-year-old right-handed tennis player presenting to your office with ongoing right elbow pain beginning abruptly 5 weeks ago during a high school match. She was previously seen by her primary care doctor soon after pain began. X-rays at the time were read as unremarkable. On your exam, you find tenderness to palpation over the lateral elbow with swelling of the joint and limited range of motion on extension. Strength is difficult to assess due to pain. What is the next appropriate step in the management of this patient? Now, this is a fairly typical presentation for somebody with an OCD lesion where you are going to have an acute injury representative of the disruption of the subchondral cartilage from the underlying bone, or the cartilage from the subchondral bone, and it can be missed on X-ray at times. Now, a 15-year-old is certainly still potentially in the age range to have Panner's disease, but check out our other video for further discussion on that. But what bothers me is that she's old enough where you would expect that the ossification centers to have pretty much fused at this point. What also bothers me about this is, or what would bother me about a patient in this situation, is that she has limited range of motion on extension. Limited range of motion in a child is almost always going to be suggestive of some fracture or intra-articular process which is preventing them from entirely using the joint itself. With full range of motion, somebody with lateral elbow pain could simply be tennis elbow, as she's a tennis player. But the limited range of motion makes me concerned. Generally speaking, osteochondritis dissecans lesions can occur chronically or acutely, though in this case we're seeing an acute case. Chronically, they may present similarly with worsening pain with activity, often without this particular inciting event. And in terms of the next step of management for this patient, it would be to first of all, understand or have a high clinical suspicion for osteochondritis dissecans, and then to proceed with more advanced imaging, as that will dictate the treatment process. In the meantime, though, let's take a look at her X-rays, actually. Only after we've discussed, though, of course, the relevant clinical anatomy. Beginning on the image on the left, we have an anterior view of the elbow. We can see the capitellum here on the left, the trochlea on the right, serving as the respective articulation points for the radius and the ulna. Now, the radius isn't perfectly visualized here, but we can see the radial head as it would articulate over the capitellum. And in the elbow, this is the most common site to have an OCD lesion, or an osteochondritis dissecans lesion. Medial to this, we have the ulna as it articulates over the trochlea, and again, not clinically relevant in this moment. We can see here, though, from this image, the blue representing the actual articular surface of the elbow, how with a lesion in the capitellum, that you're actually going to have a lesion, or this represents a lesion over the area of articulation of the radial head, not only indicating to us why it would be painful, but also why it will often present with mechanical symptoms. Again, the swelling or the limited range of motion. An osteochondritis dissecans lesion at its root is the beginning or continuation of instability of cartilage overlying bone. In its most basic form, you'll simply have inflammation. However, as it progresses, the cartilage itself can become entirely detached from the underlying bone. This can then act as a loose body, and when you have somebody with mechanical symptoms, it could be because of this loose body, actually, that you're seeing an inability to, for example, extend their elbow. Continuing on to look at the X-ray, we now have a basis to see, first of all, where we're looking. The red herring in this picture, of course, is the medial epicondyle, which more than likely represents an unfused medial epicondyle. But if we note here on the lateral side, first of all, the capitellum here of the humerus, overlying again or in articulation with the radial head, we see this lucent area of bone. And this is pathologic. This is not the normal bone that we should be seeing on the capitellum. The capitellum ought to be a well-ossified structure with a consistent echotexture throughout. This here is pathognomonic for an osteochondritis dissecans lesion in its most typical spot on the elbow. And the takeaway point from this is to look on an elbow in this spot specifically when you have a clinical suspicion for osteochondritis dissecans. Now, at this point, if I were reviewing the x-rays for this, the movement from here would first of all be to diagnose the OCD lesion, but then to do advanced imaging to better stage the lesion. Basically, an early OCD lesion can be treated conservatively, whereas a more advanced OCD lesion, one where potentially the cartilage has become detached from the subchondral bone, will need to have surgical intervention, and we'll talk about that in a moment. But first, to be able to see that, we're going to have to get either a CT scan or an MRI. If we do an MRI, of course, in this case, we can see that the area has helpfully been identified. But let's first just talk anatomically about what we're looking at. We're looking at an anterior view of the elbow. And what we're seeing here are coronal, more technically. We're seeing the distal end of the humerus here, partly in the screen. We're catching a part of probably the biceps or brachioradialis up here. And then distal to that, we're seeing the radial head. By knowing that this is the radial head, we know that we're then looking at the capitellum, and this bright echo texture here is suggestive to us of inflammation or fluid in that area. And specifically what I want to call everybody's attention to is the black line that we see coursing around this area of the osteochondritis dissecans lesion. What that suggests to me is that the lesion itself or the entirety of the bony process has become detached from the capitellum. This suggests to me a fairly advanced OCD lesion and one that's going to be more amenable to surgical intervention. Now, we don't always see it like that. Here again is that same image. And here is this image again seen from a different side. But if we look here on the rightmost image, we again are seeing the distal humerus as it articulates against the radial head, and we're seeing a little bit of the ulna over here. But if we focus over here on the radial, lateral side of the elbow and of the humerus, what we can see is that while there is inflammation in the area of the capitellum suggestive of an early OCD lesion, we don't yet see detachment of the cartilage from the subchondral bone. And this is extremely important because this patient is more likely to be able to be treated conservatively without surgery. That being said, if the patient needs to have surgery, there are several different types of surgery that somebody may undergo. You can simply affix the lesion back into the site of the original OCD insult. This is a fixation procedure where you pin it. Other potential options, though, are to do what's called a drilling procedure or a microfracture procedure. And we'll take a look at that in a moment. The other one being the Oats procedure, which is where you actually use autologous cartilage in order to stimulate or create a new base for articulation. This may feel a little complicated, but we'll talk about it actually with images right here. Now, on this image on the left, we can see the microfracture treatment. And so again, just to orient everybody, what we're looking at here is a zoomed in version of the articulation or the articular surface of, let's say, the capitellum. And what we can see here is the overlying cartilage has been clipped back. such that the subchondral bone has been exposed. What can then happen is that you can create small puncture holes into the subchondral bone, which will stimulate new growth and bleeding in the area, hopefully creating an articular surface, thereby preventing the need for further surgical intervention. However, another procedure which is sometimes used is the Oats procedure. And this, we're seeing it actually in vivo here. And what we're actually looking at is an exposed capitellum with two plugs of cartilage taken from elsewhere in the body so as to create a new articular surface. Now, these can be taken from even the same joint, often in an area where there is less or no articulation. In the knee, for example, if there's an OCD lesion, it's taken from the outside of the femoral condyles where you're not having the patella articulate against the femur. In any event, this can be a potentially catastrophic injury for an athlete, and it is important to recognize early and to treat aggressively. Just to review, though, let's remember that the osteochondritis dissecans lesion is a separation of articular cartilage from the subchondral bone underneath it, most often seen in the knee, ankle, and elbow, actually in that order, and it can be gradual or sudden. These lesions are classified as either stable or unstable based on the presence of the joint fluid underneath the lesion. Essentially, if the lesion does not have joint fluid underneath it, if you do not see the ability for that lesion to move off of the subchondral bone, then it's considered stable. An unstable lesion does have the ability to move off. You do see articular fluid or synovial fluid underneath the lesion. Physical exam, again, will have pain with extension and pronation and supination as you actually rotate the radial head through the capitellum. You'll also see often the swelling of the joint, which you can detect by careful palpation of the radiocapitellar joint. Imaging is first done with X-ray, though approximately 50% of cases will not be able to be visualized by X-ray alone. Ultrasound can be used, but because of the orientation of the radial head, it can often be difficult to actually see the lesion itself, even when present. And so therefore, the imaging modality of choice is the CT scan or preferably the MRI. Treatment, again, for stable lesions is cessation of activity with or without immobilization, depending on the patient's pain. However, for an unstable lesion or for a stable lesion which is not improving, surgery is the correct option. And the treatment options include microfracture drilling, fixation, or the Oats procedure, as we just saw. A common question about this is whether or not the presence of an OCD lesion will lead to osteoarthritis. And thus far, the medical literature does not support a known predisposition to osteoarthritis. It may still be shown to predispose people to it, though we have not seen that yet. Again, these are our references, and this will do it for our journey through the fundamentals of sports medicine today.